Hey everyone, I'm Lorna Mateo, and I'll be presenting my project on global health crises in the next pandemic. I chose this topic at the very beginning of the semester because it was relevant, and I think it's safe to say it's become much more relevant than any of us had thought. But hopefully this will shed some light on the topic and how it exists within the scope of international law. We'll start off with some background on international health law. The focus of the field centers solely on the idea that health is a public good and even a right, and the structure is more of a landscape than a set system because of ever-changing laws, practices, relationships, and power dynamics. International health law attempts to regulate biological, economic, and sociocultural determinants of health, including human rights, food safety, international trade law, and environmental law. In regards to the successful containment of infectious diseases with pandemic potential, there's a balancing act between maintaining public health using approaches that do not hinder individual rights. As we know from the current pandemic situation we're experiencing, there is a legal and ethical quandary of whether it's necessary to limit individual freedoms such as privacy, liberty, and freedom of movement in order to contain a serious threat such as COVID-19. The precautionary principle mediates this, as it supports the least restrictive measures necessary to prevent widespread negative effects from taking hold, even when there is a lack of scientific knowledge. In this context, it would hold that giving up some freedoms might be necessary to defend the greater good despite limited knowledge of the threat. The main actors in international health law are international organizations and individual states, and it seems that each actor has its own set of responsibilities and boundaries. For example, individual states' role in maintaining global health is greatly limited to their government setups, infrastructure and capacity, and their customs. The general duties related to containing infectious diseases include identifying the disease, assessing its threat, setting guidelines to a response, and finally enforcing these guidelines. To reiterate, these general duties relate to the global framework of identifying and containing communicable diseases with pandemic potential. Keeping these actors and various goals in mind, the question follows. In responding to global health crises with pandemic potential, where does the responsibility to contain infectious diseases lie? To answer this question, we will utilize 4 different cases in history to determine how diseases of this kind have been dealt with, looking at the procedures and impacts of both international organizations and individual states. The first case we'll look at is the 1918 Spanish flu. The main actors at this time were European and American public health departments. The Committee of American Public Health Association was the main source for recommendations as well. Even in 1918, the suggestions to aid in containment look a lot like the ones we have in place today. Limiting large gatherings, prohibition of non-essential gatherings, staggering of opening and closing times for essential businesses, the promotion of disinfection and sterilization methods, and the use of masks. Despite these suggestions, each state handled contagion separately in the absence of an international organization dedicated to global health. And this little saying is an interesting tidbit. It goes, "Obey the laws and wear the gauze. Protect your jaws from septic paws." I definitely think we should get that trending. The next case is the 1976 swine flu, and the global narrative was more succinct at this point because the World Health Organization was established, and the US government was important in this as well. The 1976 swine flu highlighted several factors at play in the balance of international organizations and individual states in fighting communicable diseases. The U.S. identified this strain of influenza in Fort Dix, New Jersey, and notified the WHO, which called an emergency meeting to gather recommendations for member states, coordinating research with the CDC. Although many states were actually relying upon the WHO to help them develop a response, it was clear, though, that these organizations were heavily reliant upon states to actually implement them. It was also clear that individual states were limited by the capacity of their respective public health systems. And like I said, this case is just one example of the fickle dynamics between states and international organizations in the global response to infectious diseases. After former U.S. President Gerald Ford announced a widespread vaccination plan for this swine flu, a WHO official was quoted expressing surprise at the plan. This comment was considered inflammatory, considering the U.S. Public Health Service had sworn up and down that it had been working closely with the WHO. It resulted in immense pressure placed by U.S. officials on the WHO to publicly endorse the plan. Even following the WHO's eventual endorsement, the U.S. public health system and World Health Organization became competing sources of information once the WHO decided not to include widespread vaccination in its global recommendations. This was mainly because the capacity needed to build and distribute enough vaccines for an entire population was not really a realistic possibility for most states. The next case we'll look at will be the Severe Acute Respiratory Syndrome, or SARS, of 2002 and 2003. This case proved to be a real test of the precautionary principle because ethical questions surrounded a number of response practices. The first is surveillance and contact tracing. The purpose of doing so was to identify disease hotspots and map the spread of SARS. There were many questions of whether this infringed upon infected individuals and their close contacts' privacy, which was further complicated by states' responsibility to be transparent with their citizens on the true gravity of the situation. Lastly, stigma was a factor as stereotypes and racist behavior were aimed at Chinese people because of the disease's origin. Another response which warranted ethical questions was the practice of isolation and quarantine. The decision of exactly who should isolate was a question in itself, not to mention whether the forced quarantine of healthy persons infringed upon individual liberty, especially in economic aspects, because forcing healthy people to quarantine prevents them from working and having an income. Travel advisories and restrictions were also contentious because they could be seen as infringing upon the right of movement. Not only this, but in the U.S. and other states, immigration and customs agents were given the ability to detain travelers with symptoms of SARS. Despite all the ethical questions surrounding these practices, under the precautionary principle, these actions are warranted, even despite scientific uncertainty. The last case we'll cover is the 2009 swine flu. This was the first test of effectiveness of the international health regulations put in motion by the World Health Organization. The international health regulations exists to prevent, protect against, control, and provide a public health response to the international spread of disease. The scope of this legislation also includes concepts of human rights and free trade. The 2009 swine flu was the first public health emergency of international concern under the new regulations because it fit the bill as an extraordinary threat to other states, prompting a coordinated international response. Some of the requirements include a responsibility of states to report events that qualify as a public health emergency and report new subtypes of human influenza. Beyond this, the WHO gained authority to bypass official state reporting through the Global Outbreak Alert and Response Network. States must also maintain protections of human rights for travelers and limit trade restrictions to those absolutely necessary given scientific evidence. Despite all this, the WHO still has little authority to enforce these regulations, especially considering the U.S. decline to full compliance of these regulations, and Canada questioned the WHO's legal power to begin with. As stated previously, these regulations were also limited in that some states were and remain to be unequipped to enforce them. Going back to the original research question, where does the responsibility of containing infectious diseases lie? Looking at these cases, it seems to be a partnership between international organizations and individual states. All information considered, it is a responsibility of individual states to identify new diseases and report this information to the WHO. Next, it is the WHO's responsibility to assess and determine the level of threat and provide recommendations for individual states to then enforce, given they want to and are equipped to. Thanks for watching, guys. Remember to wash your hands and don't touch your face. We will get through this. Have a great day.